Sir, are you there?
Yes.
Okay. So I think we should start.
Yeah, right. I am ready.
Okay. So a very good afternoon, everyone. Thank you to each and every one of you for being here with us today. It is with great pleasure that I greet you on behalf of the Ultrasound Innovators second edition of an online Radiology Conclave, scheduled from 18th to 19th of December 2020. The event is organizing in association with CREST, which is based out in Kochi and involving training of for radiology residents, which included case discussion, spotters, and mock exams. The program of CREST stood out for its sheer content and high academic standards, backed by accomplished faculty of which most were examiners. And the more as the whole event is sponsored by BPL Medical Technologies, which is a pioneer in the Indian medical devices space since 1967. They have partnered with South Korean-based Alpineon in 2015 and offer co-branded ergonomically designed ultrasound machines with superior image quality. They also have different range of products in ultrasound like eCube B5, eCube i7, eCube 8 series, eCube 12, and eCube 15. So today, the whole event is like split into two different days and two different sessions. So today we are first session of the first day of event, and the session is scheduled like the first session is like is based on fetal radiology, and the session is like delivered by Dr. Rijo Matthew sir. Is the chairman Samrakshan and National IRIA Secretary for IRLA Kerala chapter. And the behalf of BPL Medical Technology, we have like presenter named Preeti Vimal. She is a national product manager for ultrasound in BPL Medical Technology, and she is mainly looking for high-end range of products. She is having an experience of 14 years with multiple company and medical space. And the second session of today's event is delivered by Dr. M.L. Anthony, is a senior consultant and head Lisi Institute of Radiology Research and Imaging Sciences. So let's kick start our show. Over to Dr. Riju sir.
Thank you, Jitendra. Thank you for that nice introduction, and all my best wishes for this venture on this Ultrasound Conclave, Ultrasound Innovations by Microbios. So let's move to today's topic that I'm going to cover, ultrasound innovations, the fetal radiology, and the Samrakshan. If you look at the way the technology develops, technology, as you all know, is leverage. So doing more with less. So that has been one of the cornerstones of human progress, human prosperity. And who brings us the recent advances and new concepts in our practice? This is, if you look at this particular question, if you try to answer this question, in the practice of a radiologist, especially if you look at ultrasound, who brings us the recent advances and new concepts in our practice? Basically it comes from the industry, research and development, in collaboration with the experts in the tertiary healthcare centers. Basically, the industry, the technology develops mostly in the West, and the West basically coordinates and collaborates well with the tertiary healthcare centers and the experts in those centers, with very less involvement or participation from tertiary care centers in India. And similarly, the technology development in India is yet to take place in a big way, especially in medical technologies. I can see a lot of Indian companies now putting a lot of effort into that. But overall, if you look at it, it comes basically from the West, percolating down into developing countries in collaboration with the experts in tertiary healthcare centers, predominantly in the West. So what happens is, if you look at the ultrasound technology that developed from 1980s to 2000, from the grainy images to the high resolution images, the focus basically was on the structure, the placenta, the fetal environment, and the fetal structure. But in 2000 onwards, two important developments that took place. One is a description of nuchal translucency as a marker for chromosomal abnormality, specifically Down syndrome, by Nicolaides group. And the second one is the development of the Human Genome Project, which got completed in 2003, which started in 1984. The US and the developed countries took it up in a big way, and it was completed. The Human Genome Project was completed in 2003. So these two developments gave rise to a new technology that is genetic markers, genetic technologies, genetic labs, genetic clinics. And they got a better foothold, and they started, their influence started percolating into the fetal imaging or even into the fetal diagnostics. So it was basically from 2000, we will see the aneuploidy screening becomes the major direction of fetal diagnostics. Is that the true reflection of the ground realities that is happening in our country, especially in the secondary healthcare and the primary healthcare? If you look at the statistics of the Indian population, of the indices of perinatal mortality, or the stillbirth rate, or the causes of all these things, we will come to know that it doesn't reflect this technology and the orientation that has been now given to the fetal scans or the pregnancy scans doesn't reflect what is happening in the secondary healthcare and the primary healthcare. The aneuploidy screening or the markers for aneuploidies has been developed, like NT, NB, nuchal translucency, NB, tricuspid insufficiency, the reversal in ductus venosus. There are a number of soft markers, and the whole focus is to detect a Down syndrome baby or a chromosomally abnormal baby. Look at the incidence of Down syndrome in our country. It is said that it is 1 in 700, or take it as 1 in 500 or 1 in 600. We have got 2.7 crores of live births in India every year, approximately 3 crore pregnancies. And 1 in 600 or 1 in 700 will hardly translates into 1 in 38,000 or less than 1 in 50,000. So what we are targeting with the present orientation of the pregnancy scans or the fetal scans in our country right now is to get hold of this 1 in 50,000, that is 38,000 Down syndrome babies or 50,000 chromosomally abnormal babies, because radiologists spend quite a lot of time, quite a lot of their resources and their skill sets to detect the aneuploidy markers and aneuploidy babies. Now, I'm not against that; it is required, but there are much more important things that has to be given priority. If you look at the congenital anomalies, again, this is another category that presently the fetal scans or pregnancy scans are paying more attention to. Apart from aneuploidy markers, aneuploidy screening, we are paying a lot of attention to anomalies. Of course, it is needed because 1.9 to 2.72% of pregnancies can have anomalies. That translates roughly to 6 lakhs babies with congenital anomalies in our country. But you look at the incidence of maternal mortality, 13 per 10,000 live births. Incidence of preeclampsia and eclampsia in India. Incidence of hypertensive disorders in pregnancy. 8 to 10% of preeclampsia. Out of the 3 crores pregnancies, nearly 30 lakh mothers are likely to get hypertensive disorders. A preeclampsia in another 20 to 25 lakhs. And the incidence of small for gestational age, less than 10 percentile of effect with fetal weight, and the fetal growth restriction is at 36.5% and 54.54%. That means it is 1 out of every 3 baby that you come across is likely to have small for gestationally, or a small baby with fetal growth restriction likely to. So what are the importance of these statistics that I'm trying to show here? These are the babies that are likely to have more problems in the perinatal period, likely to add on to the numbers of perinatal mortality and perinatal morbidity, and also will add on to the neonatal mortality and later on into the infant mortality rate. I will go into the details later. So Samrakshan is a project of Indian Radiological and Imaging Association that wants to focus on this particular segment of fetal growth restriction and preeclampsia, because those are the real big numbers as far as our population, Indian population, are concerned. We do not say that we do not have to look into aneuploidy screening or aneuploidy markers or not into anomalies. We have to, but we need to prioritize our fetal scans and pregnancy scans in such a way that screening for preeclampsia and fetal growth restriction has to be given its right place, has to be given the due importance. And that is what the focus of Samrakshan, the national project of Indian Radiological and Imaging Association, intends to do. So the scope of this talk is basically on Samrakshan and its protocols. And those who are listening to this talk may wonder, what are my credentials to talk about all this? I currently head, as Jitendra mentioned, I'm the chairperson of the Samrakshan project of Indian Radiological and Imaging Association. And I've been in my radiology experience of last 28 years, I've made some significant innovations or contributions to this field. One of that is when in 2000s, what as I already mentioned, what has happened is the whole focus of pregnancy and fetal scans was changed to aneuploidy screening. Still it is there. But then from 2005 onwards, I was the one who was promoting the concept of targeted imaging. And maybe in 2010, the first lecture that I gave in India was on in the Foxy Forum on TIFA scans, that is the targeted imaging for fetal anomalies. That was probably the first lecture on TIFA scans in India. That I tried to define a TIFA scan and wanted people to pay more attention to the whole body evaluation of anomalies, not only into the aneuploidy screening or not only into the fetal echoes. We need to have a whole body picture, whole body scan, and the targeted imaging for fetal anomalies, the TIFA scan, the concept, and it was defined 10 years ago. In 2012 and 2014, I again introduced a concept called synergistic fetal imaging, which is a combination of a targeted fetal anomaly scan with ultrasound, along with a tailored approach using the fetal MRI to solve a particular problem, either related to brain or related to the fetal body. So this is called as a synergistic fetal imaging, where the due place of fetal MR in the evaluation of fetal imaging, in the evaluation of fetus, has to be brought forward. It still is an area that has to be explored further. In 2017 to 19, I've introduced a concept called FITRADS or FIRADS, something similar to the reporting and data systems that are prevalent in other areas like BIRADS in breast imaging, or TIRADS in thyroid imaging, or LIRADS in liver masses. So similarly, the reporting and data systems, or the radiology assessment and diagnostic score as far as fetal imaging is concerned, is required, which takes into consideration a holistic approach. That is why I introduced the content validity of the FITRADS concept, which was introduced. I will go to that later. And in 2018 to 20, this project of Samrakshan was introduced. So what I'm trying to say is, these are my credentials to talk on this subject. So I've been a close listener or a watcher or a learner for all these years, and have introduced certain of these concepts when I felt that these are the areas that has to be filled in, and these are areas where I have to chip in. So this talk will include the preeclampsia screening protocol of Samrakshan, which has to be an integral part of the 11 to 14 week scan. Currently, it is not. And secondly, the concepts of early and late onset FGR and the Dopplers, the role of Dopplers in fetal growth restriction, and the use of percentiles in biometry. These are areas that needs to be explored in the coming years. And whatever subduction project, whatever data that has been collected, we have published it, and that data analysis and the insights from that data will also be shared with you. And I'll also explain the problems in implementation of subduction in India. If you look at the way a certain consensus develop in fetal imaging or in medical practice, they're generally called as the Delphi consensus. So the Delphi is a temple in the old Rome where the god or goddesses were asked for with certain questions, and the main priestess there will answer for them, for them. So that those are the wise men or wise women in those days who collects together, gathers there, and tries to answer and get some sort of a consensus on the problems that they faced in their daily life, or either personally or either individually or as a community. So Delphi consensus, you can see the Delphi consensus in many of the literature that we come across. But Delphi consensus basically comes from experts in the tertiary care centers of West, or tertiary care centers of most of the countries. So what happens in the secondary and the primary care healthcare levels is not yet become a part of the consensus or the management. So that is a major lacunae that has to be addressed. If you look at the fetal evaluation, there are three components: the fetal structure, the fetal maternal environment, and the fetal growth. These are the three major parameters that has to be evaluated during your fetal scans. That is why I introduced this concept of FIRAD scoring. FIRAD scoring is basically a risk assessment system to stratification of risk of babies and mothers, depending on the findings that we come across, whether they are low risk or a moderate risk or a high risk or very high risk that necessitates termination of pregnancy. So I'm not going into the details of these FIRADs right now because that's entirely a different talk. But the point I wanted to make is, again, this one: the structure, the environment, and growth. These are the pillars on which the pregnancy scans or the fetal scans are built on. So this has to be given, all these components has to be given sufficient, it has to be sufficiently addressed in the reports. Just an aneuploidy screening is only one part of a structural evaluation. Anomaly is one part of the structural evaluation. If you don't evaluate the fetal maternal environment, right now the fetal environment, it is not just the placenta alone. We need to look into the mother as a whole, the cardiovascular system of the mother, the renal system of the mother. Everything can contribute to the well-being of the fetus. So it's time for us to think beyond just as the placenta, as the placenta, and the uterine environment as the fetal-maternal environment. The researchers that are coming from nowadays are pointers to consider the mother as a whole, not just the uterus alone. And growth is a very important parameter. That is what I was saying in one of the conferences earlier. In 2010, when I defined and introduced this concept of STIFA, I did not give much importance to growth. I was giving importance to the anomaly, the structure. What I was trying to say that is, it's a whole body evaluation that has to be done. It is not just aneuploidy evaluation. It's not just the fetal heart evaluation alone. We need to see the fetus as a whole. It's time to redefine anomaly scans, and we need to consider it as a whole body scan. So whole structure was what I was emphasizing on that in 2010. Looking back from 2020, I realized that a much more important parameter of fetal growth that was not given sufficient importance at that point of time. That is why in 2017 onwards, the project of subduction was brought in, and the importance of subduction, the highlight of subduction is to look into the fetal growth. It is because the abnormalities of the fetal growth are contributing to the perinatal mortality and the perinatal morbidity in our country. Fetal growth restriction may not be a major issue in the Western developed countries. If you look at their FGR rates, it's 1 to 3%. But if you look at the fetal growth restriction in India, it is 26%. If you look at the preeclampsia rates, it is very, very less in the West. If you look at the preeclampsia rates in India, it is nearly 8 to 10%. So their problems are aneuploidies, the fetal heart abnormalities, congenital anomalies of the heart. Their problem, they are giving more importance to that. There is enough justification for that. When we ape West, we forget our ground realities. So fetal growth is one important parameter that has to be serially integrated into our fetal scans or the pregnancy scans. So with that focus, let me introduce this project of IRA or Indian called Samrakshan. It's a national project to reduce perinatal mortality in India. It aims to help reduce perinatal mortality in India in a systematic phased approach. It trains and guides radiologists to work for a better perinatal outcome. It was developed by me and it was launched by Dr. Hemant Patel in June 2019 during his presidency. If you look at the perinatal mortality all over the world, Sub-Saharan Africa and South Asia, which includes India, these two regions contribute to 85 to 90% of perinatal deaths all over the world. If you look into our country and then they compares that with the world, out of the 12.8 crores of live births all over the world, 2.7 crores happens in India. That means roughly 20-25% happens in India. Low birth weight babies, there are nearly 20 million all over the world, and we have nearly 8.1 million. Stillbirth rates, 26 lakhs in all over the world, we have nearly 6 lakhs. That means nearly 25% is from India. Look at the perinatal mortality rates. Perinatal mortality, if translated into roughly into numbers, although all over the world it is 28 lakhs, 7.2 lakhs in India. Again, 25% comes from India. Similarly, for neonatal mortality rate and infant mortality rate and child under 5 mortality rate, if you look at it, India contributes to 20 to 25% of the world statistics. So this is high time that all Indians, especially the practitioners in medicine in India, has to look at this along with the policymakers in India. In India itself, region-wise, we have got a lot of variations. These 5 states, Rajasthan, Uttar Pradesh, Madhya Pradesh, Chhattisgarh, and Odisha, they contribute to 55% of perinatal deaths, perinatal mortality in India. Gujarat, Bihar, Jharkhand, Assam, Jammu, Kashmir, and Haryana contributes to another 20-25%. So if we need to concentrate on these states specifically to address the issue of perinatal mortality, neonatal mortality, and infant mortality in India. So the goal of Samrakshan is to supplement and complement existing efforts to address perinatal mortality in India through a synergistic and holistic approach that includes all stakeholders in fetal care. It's not that governments and the non-government organizations are not paying attention to these statistics. They are, but their focus is on primary prevention. Their focus is basically to improve the quality of life of the individuals in these particular areas, their nutrition, but what a Samrakshan focusing is into the use of technologies to identify those babies and mothers who are at risk for perinatal mortality or maternal mortality. So use of technology can accelerate that process. We can categorize, we can stratify the risk group and pay more attention to that. This is how we need to interfere in this. We need to play our role in this particular issue. So the various subcommittees were formed. One for us academic, because this has got a skill enhancement component. We need to train the radiologists to understand this process, to identify these at-risk mothers and babies for preeclampsia and fetal growth restriction. And there was a statewide continuing medical education and training programs which are organized by the IRA state chapters. Many IRA office bearers have played a significant role in organizing the state CMAs for Samrakshan. which was first organized in Indore by the Madhya Pradesh State Chapter and again by Uttar Pradesh State Chapter. Then the evaluation, whatever we are doing, we need to collect that data and see, evaluate that data and understand how we are contributing to the statistics, how we are contributing to how we need to modify the parameters, how we need to change the course of our training. And awareness, the social media campaign that has been spearheaded by the IRA, by our Joint Secretary of Kerala IRA and Dr. Ramesh Shennai, who played a significant role in coming out with the social media awareness campaign on subjection. Policy and guidelines is another committee that looks into how we can formulate a policy and so give it to the health ministers and the health officials. And another committee was formed for synergy and reach out to the other stakeholders like the obstetricians, neonatologists to address this particular issue of perinatal mortality. There are online and offline training programs. There are standardized data forms. We can submit the online data in the IRA website, which will be collected in the general pool, and these data are dedicated data is analyzed and published on regular basis. There are monthly reports and state-wise data analysis. The research protocols for faculty research and student dissertations also been provided by the subjection team. And two of the students, one from JIPMER and one from Amala Institute of Medical Sciences, they got the ICMR fellowship on the subjects related to subjection. We are very proud of them. So, to the two major determinants of perinatal mortality in India are preeclampsia and fetal growth restriction. So, why perinatal causes are important? Because it contributes to contributes to 70% of early neonatal mortality. Again, that contributes to 60% of neonatal mortality, and 60% of neonatal mortality is a big number as far as the infant mortality is concerned. So we need to address this perinatal deaths, perinatal mortality, which if we can reduce it at that level by addressing preeclampsia and fetal growth restriction, will definitely subsequently reduce the early neonatal mortality, neonatal mortality, and infant mortality in India. If you look at the causes of perinatal deaths or the neonatal deaths in India, you will be surprised to know that 43.7% it is due to prematurity, preterm birth and prematurity and related complications, and 20% is related to intrapartum related complications. So look at the perinatal deaths due to congenital anomalies. It's just 8.1%. Our whole focus is to detect congenital anomalies and aneuploidies. But if you can understand these figures, 71% of babies die due to preterm, prematurity, and during pregnancy. So you need to understand that 7 out of 10 babies are dying because of reasons not related to aneuploidies or structural anomalies. It is related to growth. It is related to fetal environment. So we need to look into these perinatal deaths in a very serious way. That is what subjection aims to do. Those of you who have got doubt on what perinatal period, it commences from the 28 completed weeks of gestation and ends 7 completed days after birth. Perinatal mortality includes the late fetal mortality, that is stillbirths, plus the intrapartum deaths, plus the early neonatal deaths, that is after 7 days after birth. Again, I'm emphasizing that particular problem of that we are addressing in subjection. The core process here, we need to integrate Doppler in our pregnancy scans. It has been a neglected area so far. In our quest to look for markers of aneuploidies and structural anomalies, we have neglected Dopplers, because Dopplers help you to identify fetal growth restrictions earlier. Dopplers will help you to estimate the risk of babies, stage them, and Dopplers will help you to prognosticate it and will help you to guide the management for timing of delivery and of pregnancy delivery. So I'll just briefly go into the preeclampsia and fetal growth restriction protocols, if time permits. Yes. So preeclampsia is a multi-system syndrome developing during the second half of pregnancy characterized by hypertension, proteinuria, and maternal organ dysfunction. It's a major cause of maternal and perinatal mortality and develops in 2 to 5% of pregnancies. So what happens in fetal preeclampsia is there is a reduction in the size of the cytotrophoblast, fail to adopt an invasive endothelial phenotype, and the inversion of spiral arteries is shallow. They remain small caliber, and the resistance of vessel increases. Subsequently, what happens is a placental insufficiency or a placental ischemia, which leads to the reduced amount of blood supply or oxygen to the fetus in fetus. So uterine artery Doppler can be a pointer towards abnormal placentation. The waveforms of uterine artery Dopplers can tell you whether the placentation is proper, whether the baby is getting sufficient oxygen. So how do we categorize these babies or these mothers who are at risk for fetal growth restriction and for preeclampsia? There has been several guidelines proposed by the Obstetric Association, the NICE guidelines, and etc., which looks only into the maternal history, maternal factors. The mother is having blood pressure, or the mother had a previous history of preeclampsia or pregnancy-induced hypertension, and if there are if the birth weight was less. So all these factors has to be considered. Here in preeclampsia screening, we take 3 parameters basically. Those are the maternal history, which takes into account their height, weight, the blood pressure, the mean arterial pressure is checked, and also the uterine artery. So this is Dr. Devarajan. He's course instructor for Samdekshan first trimester. He has published his lectures in the Samdekshan library that is available in the Indian Radiological and Imaging Association website, ira.org.in.
How to be collected can be filled in first trimester form that is available in Samdekshan.
The second part of the preeclampsia screening, it's a combined screening, as I mentioned earlier. So you need to take the maternal history. Your staff can be trained to take the maternal history. Second thing is to take the mean arterial pressure by using two automatic BP apparatus that has to be taken simultaneously. This is the manner in which it has to be taken. It has to be taken twice, and after 5 minutes, between the interval of 5 minutes. So you can get all these details from the lectures that are available from the EC class platform and the Samdekshan library that is available in the ira.org.in site. That's the National IRA website. And the third step is to measure the uterine artery Doppler percentile PI. So the uterine artery on right side and left side are measured. Get the sagittal section of the cervical canal, then put color flow and gently tilt the transducer side to side and to get each uterine artery along the side of the cervix. The sampling gate is set at 2 mm and the angle of inclination should be kept less than 30 degrees. So that's the way that you have to. And the peak systolic velocity of sampled uterine artery should be more than 60 centimeter per second. If it is less than 60 centimeter per second, even after this angle correction and the sampling gate of 2 mm, probably you are not looking at the main uterine artery, you're looking at one of the branches. So you need to evaluate, get it right again. So this is how you take the uterine artery. It is very, very simple, not difficult as getting an NT nuchal translucency. It's 1/10. The difficulty index is only 1/10 of getting an NT.
So once we finish all these 3 steps, we have to calculate the risk. We are using FMF calculator. So for that, just go to Fetal Medicine Foundation website. In that, in left side corner, you will see the space for calculators. You have to click on prediction of preeclampsia. So if you click, there will be options for 3 trimesters. You have to click at 11 to 14 weeks. Then the calculator will open. So you have to enter all the variables
we have corrected in the form.
So that was Dr. Devarajan explaining to you how to calculate the risk from the Fetal Medicine Foundation calculator that we are currently following. And maybe when our data comes up from our population, we will be able to come out with much more specific data and may be able to develop our own calculators. So once the risk is calculated, we come to know from preeclampsia risk from history plus mean arterial pressure plus uterine artery PA. If it is less than and similarly, you have to calculate the FGR risk. And if it is less, if it is 1 in 150 is considered as a cutoff for increased risk in Indian women. So West has taken it as 1 in 100 because their incidence is less. Our incidence is almost 3 times of that in West. So we have taken, in some direction, we have taken 1 in 150 is considered as a cutoff for our population. And we are currently analyzing the risk for 1 in 150, 1 in 100, and 1 in 50 from the whatever data that has been collected from the subduction forms. Nearly 6,000 researchers, 6,000 data has been collected, submitted by more than 10 researchers from different states all over India as part of this project. So we are analyzing that. So why this is important is preeclampsia screening. If it is screen positive, we can start aspirin 150 mg at bedtime, and it is recommended to be started before 16 weeks, which can be continued up to 36 weeks. This simple measure can reduce the incidence of preeclampsia to nearly 60 to 80%. So that will be a huge reduction considering the numbers of preeclampsia that we have. So if the risk is less than 1 in 150, the women can be reassured and called for a reassessment at 20 weeks of time, 20 weeks at the time of the TIFA scan. So how do we report the 11 to 14 week scan? The most important element of an 11 to 14 week scan right now is dating, as far as India is concerned. If you look at a paper that was published by Dr. Lalit Sharma and our team in the April issue of Indian Journal of Radiology and Imaging, after evaluating more than 14,000 pregnancies, we have identified, we have come to the conclusion that nearly 50% of ladies in India do not know their LMP, or if we calculate expected date of delivery from the LMP given by them, it is either going to be an overestimation or an underestimation. So you're going to the percentile calculations in the third trimester can go awfully wrong if you go by the LMP. So you need to get a corrected EDD, or the dating of pregnancy has to be correct from the early scans, and 11 to 14 weeks is the ideal time for that. Aneuploidy screening is right now given a lot of importance, and NT-NB scan, which has to be given. And second one is early detection of anomalies. Early detection of anomalies also has to be done. And the most important one is the uterine PA and the risk assessment and for PA, risk for preeclampsia and fetal growth restriction screening from maternal history, mean arterial pressure, and mean uterine artery PA. So the 4 components, for 5 components of the 4 components of 11 to 14 week scan. Dating, I will give the utmost important. Second important priority, I will give for risk assessment of preeclampsia and fetal growth restriction. Third priority, I will give for anomaly screening. And the 4th priority, I will give for aneuploidy screening. So the recommendations, if you can, if there is a screen positive for preeclampsia and fetal growth restriction, a simple measure like low-dose aspirin, if given, can reduce the incidence of preeclampsia and fetal growth restriction by 60 to 80% in India. And we also recommend the filling up of subduction forms, because that can form a huge database for India. And that research is subduction encourages research from practitioners, clinician practitioners in all over India. This is how our subduction forms look like. You can access them to the Indian Radiological and Imaging Association website, iria.org.in, and go to the subduction link. You can get a description about the project. You can access the forms, and you can even submit the forms online. I'm not going into the details there. As I already mentioned, the detection rates, if by using the simple method of maternal history, measurement of mean arterial pressure and measurement of uterine PA can detect nearly 80%. And if aspirin is recommended for them, you can reduce the incidence of preeclampsia and fetal growth restriction by 60 to 80%. If you add the biomarkers like placental growth factor or pregnancy-associated plasma protein A, again, the detection rates can go up 90%. As of now, some detection do not recommend it at this point of time because of the affordability and accessibility considering a pan-India perspective. But sooner or later, once these biochemical markers are available all over India, we will be soon adding into our protocols. As I already mentioned, subjection is giving utmost importance to research, the data submission. There are subjection researchers all over the country. From every state in this country is submitting forms. And on whatever data that has been collected, we publish them in the journals. In the Journal of Fetal Radiology, this is one article that has been published. Subjection first trimester screening identifies 1 in 5 pregnant women as high risk for preterm preeclampsia and fetal growth restriction. So this 16.27% of women had mean uterine artery PI of 95th percentile. And MAP and mean uterine artery PI significantly associated with preterm PE risk that has been proven again. In the second trimester, if you're following it up and if you're instituting low-dose aspirin, we have seen a significant reduction of from 9.98% to 3.09% by integration of mean uterine arterial PA Doppler with effective fetal weight and fetal AC percentiles. So that is about the first trimesters. As I mentioned earlier, the focus of subjection is on preeclampsia and fetal growth restriction screening in first trimester, second trimester, and third trimester. Now, another area that fetal growth restriction has to be focused, because this babies who are likely to go for fetal growth restriction, preeclampsia, detection of preeclampsia is important. And as the pregnancy advances, throughout the pregnancy, as I mentioned earlier, abnormalities of growth, the fetal growth restriction, can significantly contribute to perinatal mortality. So diagnosing fetal growth restriction is of utmost importance. Understanding the concept of early and late onset phenotypes of fetal growth restriction. There are two different phenotypes, two different entities. This has been described by the Barcelona team, the Figueras, and the Edward Greteco's team. That's major contribution from them that has come out in 2013-14, which helped us to identify those babies who are at risk, and those babies who develop early fetal growth restriction. And there is a significant group called late onset fetal growth restriction, which goes undetected most of the time and are more likely to turn up with stillbirths or perinatal deaths. So staging of FGR and their surveillance is important, and it also helps us to assist and time the delivery. As I mentioned, if fetal weight calculation, fetal weight or AC, abdominal circumference less than 10th percentile is still considered as the cutoff limit to detect whether the baby is small or normal. This is an arbitrary cutoff. This is increasingly being challenged by more and more researchers all over the world, and the subjection research in India was also challenging that. It's time for all of us to take the cutoff of 10th percentile as to categorize the baby as normal and abnormal. It's only one of the parameters. We need to consider Dopplers. We need to consider the staging, hemodynamic sequences with Doppler. We need to consider the fetal breathing movements. We need to consider the Leica. We need to consider the fetal environment, other parameters also into this. And again, this is one area that I want to highlight in the subjection research in the last 1.5 years, that we have seen that those babies above the fetal weight percentile of 10th percentile with abnormal Dopplers, they are the truly invisible high-risk category in India that we need to pay more attention, because they are contributing to perinatal deaths. We think that if you take arbitrary cutoff of fetal weight of 10th percentile and leave them alone, if we don't monitor them, if we don't do a Doppler for them, we may not be able to pick up this invisible high-risk category of fetal weight more than 10th percentile, but with abnormal Dopplers who are likely to go for perinatal death or morbidity. So this is what subjection, because babies will show when integrating Doppler into the fetal scans, in the pregnancy scans, you will be able to stage the hemodynamic sequences at which babies are at. Because once there is a significant reduction in the oxygen content that is coming from the maternal circulation, babies has got a natural tendency to adapt. So it tries to spare the vital organs of a brain, adrenal, and heart. And it reduces the blood supply into the peripheral areas, into the abdomen. That is why the abdominal circumference reduced. That is why there is reduction in Leica. That is why Even kidneys are not an important organ for the baby at that point of time, other than brain, adrenal, and heart. Kidneys are not a very important organ. That is why kidneys are not given enough blood. That is why there is less amount of urine being generated, and that is why there is less liquor also. So we will be able to stage the fetal growth restriction depending on the adaptive responses the baby shows by analyzing the vessels of uterine artery, umbilical artery, middle cerebral artery, the ductus venosus, the fetal aortic isthmus, and also the umbilical vein. If you look at all these vessels, it's not necessary that in all cases we'll have to go and analyze all these vessels, but depending on the hemodynamic stage at which you are seeing it, you may have to add on the number of vessels. So this classification for staging has been advised and recommended by the Edward Kretakos and the Figueres team. That is, if the cerebroplacental ratio is less than 5th percentile, if the uterine artery mean PA is more than 95th percentile, or the MCA is less than 5th percentile, or the fetal weight is less than 3rd percentile, that moves on to stage 1 of fetal growth restriction. If there is an absent end diastole in umbilical vein, or if the aortic ischemic index percentile goes to, or there's a reversal in aortic ischemic flow, it goes to the stage 2. It goes if the ductus venosus percentile goes above 95th, or if there is a reversal in diastole in the umbilical vein, it goes into the stage 3, and reversal. And this stage 3 and stage 4 are high risk conditions as far as India is concerned, because already acidosis sets in. So as I said, when there is plus oxygen deficiency for the baby tries to redistribute blood and oxygen in such a way that its vital organs are spared. But beyond a certain limit, even the vital organs start showing the hypoxemia, and that is when the acidosis sets in, and that is highly damaging for the baby. So acidosis, setting in of acidosis cannot be managed sufficiently, especially in places below the tier 2 cities in India. This is what the Samdakshan experiences tell me, especially in places like, I've been closely monitoring. There's been tremendous work that is done by Dr. Lalit Kishore Sharma and the Samdakshan project in Guna in Madhya Pradesh. He is watching, he's doing an very important work there in Guna, where he is integrated this services along with the Anganwadi workers and the district administration, the maternal and child health department, and monitoring the pregnant mothers in an area of nearly 60,000 population, where I understood that the nearest tertiary center is nearly 150 kilometers away. So if we sees any baby beyond stage 2, I always recommend, and he has also convinced that it is better to terminate that pregnancy at this stage rather than leaving them to stage 3 for some better management in the tertiary care center. By the time they reach already the damage has been done for the vital organs, and that will significantly cause perinatal mortality and morbidity. So this is how the screening for fetal growth restriction goes. And in late onset fetal growth restriction, as I mentioned, the management strategies, there are a lot of ambiguity, a lot of confusion as far as the obstetricians and the neonatologists are concerned. Radiologists too has to make the points clear here. When there is an abnormal CPR, I think it is a marker that has to be considered seriously. When there is reduced fetal movements, especially told to you by the mother, then that is important. That reduced fetal breathing movements are important. Abnormal biophysical profile and the total biophysical profile score changes to less than 5 and all happens quite late. By the time it is acidosis that has set in, so damage has already been done. So that is why biophysical profile score is no more an important evaluating parameter in 3rd trimester. We need to go for the biometry percentiles. We need to go for the growth. We need to go for the Doppler assessment and the percentiles, the staging of FGRs, and also there is another segment of small for gestational babies, that is the constitutionally small babies with normal Dopplers that survives very well, that is absolutely normal, they can go up to 40 weeks. So we have to categorize them also. Otherwise, these babies were previously categorized into the fetal growth restriction and they were becoming preterms. So just by integrating Doppler and following it up every 2 weeks, we will be able to say that this is a constitutionally small baby and that can reach up to 40 weeks, perfectly normal delivery. Samrakshan preliminary results in India. The 43% of third trimester USG fall in the 10 to 50th percentile category. 24%, one-fourth of them shows abnormal Dopplers. This is what I mentioned, the invisible category in India, which is not yet being addressed or not yet being categorized by the Barcelona or the Figueres Getecos team. This is a category that has to be newly addressed, and new parameters that's evolving from the Samrakshan researchers and the research that are conducted by other researchers elsewhere also has to be integrated into that. So this is opening up new platforms, new ideas, new insights for us. So 50% of abnormal CPRs can have abnormal outcomes. So we need to be watchful, careful about this. So Doppler examination at each and every visit, irrespective of fetal weight and growth. Staging of FGR is important, and the filling up of Samrakshan forms I recommend. This is a Samrakshan forms again. I'm not going into the details of the research outcomes. So Samrakshan basically has got a 7-star program. It's a promotional campaign. Then enroll maximum number of radiologists for online instructional course of Samrakshan technical package. They organize more and more offline and online CMEs, synergize with Reksha, PSV, PNDT, and organize Samrakshan reach out with obstetricians and neonatologists. Evaluation of audit of identified abnormal cases and state-wise data and follow-up, and to submit IRA national policy document to health ministry and authorities at central and state level to highlight the importance of our strategy. This is what some IRA is aiming for. We also acknowledge the huge effort done by obstetricians and neonatologists to reduce perinatal mortality in India. It also aims to provide supporting clinical material that can guide decision-making for improved outcomes. So it takes us to this question: can radiologists guide the pregnancy care in India for better outcomes? This is a Samrakshan team: Dr. Ramesh Shanai, Dr. Bavaharan, the National Academic Lead, Dr. Praveen Nirmalan, the researcher, chief research mentor for Samrakshan, and also he's from the Amma Research Gurukul. And Dr. Lelish Sharma, who is doing a human service in Guna, Madhya Pradesh, and Dr. Anjali Gupta in Agra, Dr. Shilpa Satarkar in Aurangabad. These are all radiologist practitioners in small places in India, not in the metros, the mini metros, or in the tier 2 cities of India. So the team Samrakshan, I have my thanks to each one of them who has, from the IRA national office bearers to state office bearers, who help to organize Samrakshan programs in different parts of our country. And also to the course instructors and the reach out program organizers of Team Samrakshan, Dr. Suresh Sabu from Jelna, from Dr. Lilith Kishore Sharma from Guna, Dr. Agamsha Bagal from Harda, Madhya Pradesh, Dr. Devarajan from Tirupur, Dr. Rajesh MG from Trishur, Dr. Shilpa Satarkar from Aurangabad, Dr. Neelam Jain from Jamshedpur, Dr. Karthik Sendilvel from Trichy, Dr. Kavida Aneja from New Delhi, Dr. Shahir, Dr. Sanij from Kozhikode, Dr. Sunita Pradeep from Pondicherry, Dr. Angur Shah from Gujarat, Dr. Supriya Gadekar from Pune, Dr. Amandeep Singh from Punjab, Dr. Anand Kumar from Chennai, Dr. Yuva Balakumaran from Salem, Dr. Renu Sharma from Sikar, Dr. Gulab Chajar from Pali, Dr. Sandhya Dhankar from Chandigarh, Dr. Srinivas Shendra from Bangalore, Dr. Prashant Onkar from Nagpur, Dr. Shweta Nagar from Indore, Dr. Varsha Sodani from Indore, and there are many more, and the list grows day by day. So thank you very much for your patient hearing, and any questions you have, I'm happy to answer.
Thank you so much, sir, for this interesting presentation and keeping us aware about this Samrakshan and all. And it was really a great session, and no doubt it's really great presentations. I'm requesting you all, if you have any question or any clarification regarding this whole presentations, so you can simply put it on the Q&A tab, and we will answer the same. I'm audible to you?
Yes, I'm audible. I can hear you, Jitendra. If you've got any questions, I can't see the question box. If you can ask me the questions, I can answer them.
Yes. If there is any questions or you can simply put on Q&A tab and we will answer, convey your question with Dr. Riju sir. Yes, sir. We have like one question from Dr. Sanjana Arora, sir.
Yes.
Yeah. From where to download the graphs for plotting the sequential growth of the fetus, and how to plot it if early ultrasounds are from outside?
See, the serial growth assessments, there are many softwares right now available. Even many of the equipment manufacturers also provide you an opportunity to enter the data that previous data. So you need to sit with your application specialist, sort it out, and most of the time it is the softwares that are available, commercially available, will help you to give this serial growth serial growth charts. So there are commercially available softwares there, and even Dr. Srinivas Shenda from Bangalore is developing such a one, and I hope he will be able to help you. You can reach out to him for this softwares.
Thank you so much, sir. Hope Dr. Sanjana is satisfied with the answer. And sir, our next question is from Manju Sri. She
Yes.
is asking, sir, how to read it in case of twins?
How to
read it in case of twins, sir?
Yeah, twins again depends on whether it's a monochorionic or a dichorionic. So early dating scans are very, very important, as I mentioned, whether it is twins or singleton pregnancies. If the early dating scan, you follow the early dating scan, the difference between the twins will be very, very minimal in your early dating scan. So you don't have to worry too much about it if you're going only by the early dating scan. Early dating scan, what I mean by that is a 9 to 13 week scan. And if you got, and especially for twins, if you got it from 8 to 12 weeks, those will be very good. There won't be much of a difference between the two babies at that point of time, unless it is a monochorionic twin pregnancy that shows shows a twin transfusion at a very early stage. But 99% early dating scans, the approach that you take for singleton will be similar for that for twin pregnancy.
Thank you so much, sir. Thanks for your answer, and hope Manjusri is satisfied with the answer. Sir, our next question is like how to assess growth if a patient has two serial scans, both scans before 13 weeks, where we don't get EFW in machine.
So we know we don't require an EFW at the 11 to 13 week scan. It's not important. Your CRL measurement to assess the CRL measurement is important there. CRL will give you the weeks, and that has to be, EFW is not a very important parameter there in the 11 to 14 week scan. That has to be, the growth has to be now calculated. The serial growth has to be understood from the to the 20 week scan, and from there onwards, if it is necessary, 24 or 28 or 32 week scan. So 11 to 14 weeks, it's a CRL measurement in the gestational weeks that is more important. It's not the fetal weight.
Okay, thank you so much, sir. Thank you so much for your answer, and hope Manjushri, you satisfied with the answer. If you have any more questions or related to this presentation, you can simply write here. Otherwise, you can simply mail to me, and I will convey your question with sir. Sir will definitely reply your answer. And sir, one more question. The question is actually from managing editor of Microbios India only, and herself is Kusum, and she is asking, sir, in India, like developing country, there is a high prenatal death rate. What do you think where we lack? Your opinion as a doctor, sir.
This is a very, very interesting question. Your editor has asked it.
Yeah.
Can I know her name?
Herself is Kusum Pal. She is a managing editor for Microbios India.
Yeah. So thank you, Doctor. Thank you, Kusum Pal, for that question. So this is a question this is an issue that has to be addressed in multiple dimensions. So perinatal mortality, I've already explained. It's not because this issue has not been addressed by governments or non-governmental organizations. There are lots and lots of organizations which is addressing the issue, but they are trying to address it at a primary level, where the nutrition, the socioeconomic factors, the lifestyles, all these things are very, very important. even the accessibility and affordability of healthcare is important. So what we are trying to do with Samrakshan is to use of technology to accelerate this process of identifying those mothers and babies who are at risk for perinatal deaths, perinatal or maternal morbidity or maternal deaths. So use of color Doppler and ultrasound to categorize it. So you need to make it accessible for them. And what we are trying as a professional organization in Indian Radiological and Imaging Association is to train and enhance the skills of our radiologists to identify those pregnancies which are at risk for perinatal deaths. So if we can identify them at very early stage, that is why our focus, as I said earlier, the first trimester screening will give you an window of opportunity to intervene. If we can identify those babies who are at risk for preeclampsia and fetal growth restriction, a simple measure like in giving aspirin to their mothers, 150 milligram aspirin at bedtime till 36 weeks, can reduce the incidence of preeclampsia and fetal growth restriction by 60 to 80% in our country. Very simple measure. But for that, you need to do a systematic evaluate screening at 11 to 14 weeks, along with your NT and NP scan, where you spend quite a lot of time. Just integrate the preeclampsia and FGR screening into your practice. This is what we are trying to do with Samrakshan. And second focus is the third trimester screening and to look for babies who are at fetal growth restriction for timing of delivery. Because if it is timed well, in a good setup where the neonatal ICU is there, the obstetric care is there, their survivability, their reduction in fetal perinatal deaths is definitely possible. So we are looking at it from a professional association's point of view, the doctor's point of view. So there can be multiple approaches to address this. Governments and non-governmental organizations are addressing it in a different way, but honestly, I believe our approach, the professional approach with integration of technology, can accelerate this process of reduction of fetal growth restriction, the perinatal deaths, the preeclampsia in a significant way if the governments and the non-governmental organization integrates our approach into their policies, as their policies. Thank you.
Thank you so much, sir. Thank you so much for your clarification and answer. So if still there is any question, any more question, you can simply write here. Otherwise, you can simply mail to me at support@microbiasindia.com or support@microbiashealth.com, and definitely we will answer a question. We will convey your all clarification and question with the Dr. Riju, and he would be happy to answer the same again and again. So without wasting time, let's start and let's step forward to our next session. Our next session is it is like a type of presentation from BPL Medical Technology, and the session will be presented by Preeti Vimal. She is a National Product Manager for Ultrasound in BPL Medical Technology, and she is mainly looking for in range of products. She is having an experience of 14 years with multiple companies in medical space. So hope Preeti ma'am is here. I am just making her presenter. Ma'am, I'm audible to you, Preeti ma'am. I just allowed to talk, and I'm audible to you now. Ma'am, are you there? Ma'am, I just allowed to talk. Are you there? Ma'am, I'm audible to you, ma'am. Preeti ma'am, are you there? Ma'am, are you present now? If I'm audible to you, just raise your hand.
Am I audible, Jitendra?
Yeah, now it's fine, ma'am. Now you are present, and you can just simply share your screen as I told you yesterday.
Okay, fine.
Okay, ma'am. You are presenter, ma'am. Yeah, now I'm able to see your screen. That's it,
Okay,
right.
fine. Okay. Thank you, Jitendra, and good afternoon, everyone. Thank you, whole team of organizers of microbios and ultrasound innovators, for giving us this an opportunity to present in this platform. I hope I am clear, Jitendra, my voice.
Yeah, your voice is clear, ma'am. Go ahead.
Okay. So myself, Preeti Vimal, and as a representative of BPL Medical, would be taking a few minutes to talk about our company and product portfolio. So BPL Medical has started its journey in 1967 with a single channel ECG machine, and then in subsequent years has launched many products. So turning point is like in 2014 when BPL has introduced the imaging products, and with the collaboration of the Alpinian Medical Systems, BPL has introduced color Doppler systems in 2014. So basically, PPL Medical Systems has many feet on ground. So like 600 plus, they have very good direct sales and application persons in the market, and a very strong channel partners and sales and service support. So these are the few major installations what we have across in India. So like we have an installation in Medanta, Apollo, Metro Hospital, Max Hospitals. So these are just few hospitals where we have installations. So in terms of color Doppler systems or the ultrasound products, we have partnered with Alpinian Medical Systems, which is a South Korean product, and these are the Seoul-based company. And they are the team of the Madison people who has been came out of the company and manufactured this company from company called Alpinian Medical Systems, and they are dedicated to ultrasound company. Why they have only ultrasound products, and they have been manufacturing a very high end system which is ultrasound guided HIFU system. And the plus point is like they are manufacturing their own probes within the premises, so they are not depending upon any third party for the transducers and all. So, and they are the first company who has manufactured single crystal technology in affordable system. So prior to this, only single crystal technology was available with the high-end systems, but they introduced in the very affordable systems like models like eCube 7 and all. And these are the only company who has been manufacturing single crystal volume probe. So with the volume probe also, they are giving this technology as a single crystal and high density. So this is the product range what we have in the ultrasound BPL Alpinian products. It is starting from EQ5 and then to EQ15. So EQ5 is our entry model and I7 is our portable series. And in the mid segment, we have ECube 8 LE, ECube 8 and 8 Diamond. So these are the three mid-range segment, and in the high-end segment, we have ECube 12 and EQ 15. They are very rich in the image quality and the color pickup. So, and these machines are based on FlexScan architecture, having a very stable image performance throughout the ultrasound life. So that's the strength of the company, like the stable. They are very stable and very durable, and easy upgradable is available. So to match up with the new technology, we have these machines are based on the solid state drive. So that's always better than the conventional hard drives. Therefore, it gives you a good fast boot up time, and also the processing will be really fast. So with the help of these two technology, like you can even when you are transferring the data to the pen drive or the external drive, that time also you can scan the patients. So that's kind of strength which SSD is giving, and with the fast processing. So in terms of the transducer technology, like I have mentioned, like they are manufacturing their own transducers. It's a crystal signature, means the technology is single crystal technology. We called it as a single crystal signature. So with the crystal signature, you'll get a wider bandwidth, and as a result, you'll get a high definition and high penetration in the image quality. So that's the kind of power what BPL Alpinian products has. Even in the very affordable systems, you don't have to go to a high-end systems to have this kind of technology. Even the affordable systems has this kind of technology. Another very strong kind of technology what we have is a power view technology. What happens like with the power view technology, there is a heat dissipation layer or backing block which continuously lowers down the heat, because ultrasound is also kind of a heat only, so it continuously lowers down the heat, and as a result your probe doesn't get heated even for the longer time when you're using it. And as a result, again you will get a very nice higher resolution imaging as well as very nice penetration. So this is the technology what we uses in the ultrasound across all models, where there are four features within this technology. Probes are very lightweighted and flexible cables. So generally we cannot twist around the cable in other products, but the cables what we are giving in LPNN products, they are very flexible. So nothing will happen to the connector end or the probe end, and we can twist around it, so again adding longer life to the machine. And the curved footprint and micro pinless connectors. So the probe connectors what we have, they are no pins in it across all models, so therefore again it adds lots of life to the product. Another technology what they uses in the product transducers, it's the amplifier. So there'll be amplifier on both end, so whatever information you are taking from the patient side, same information you will be getting onto the monitor also. So therefore you are getting a purified signals, enhanced sensitivity and high resolution images. So that's the reason you won't get many artifacts, and the penetration will be more. So that's the reason why we have this sensitive view technology. Then even our mid-range segment like eCube 8 segment also has this kind of technology, 3D 4D ultrasounds. You don't have to invest too much to get into the 3D 4D ultrasound. So this kind of technology or this kind of features we have even in the mid-range segment. So this is a normal rendered mode, and then this is a feature called Live HQ we have. Then multi-slicing is also available, and we'll have excellent color pickup in the all segments. So this is a small video what we have for the product eCube 12, which is our high-end range product. So I'll just play this. So this is our eCube 12 product, which is very powerful, and it has a combination of PowerView technology probe and the single crystal technology probe. So with 4 live probe connectivity, and also it has all optimization tool like SRI, SCI, whatever features are required to enhance the image quality. Features like XSpeed, which is an auto optimization tool, single crystal transducers are available, and then it has a power view probes also, so you have a wide range of probes available. And the workflow is really simple, like you can create power presets to make your workflow simple. 21.5 inches full HD LED monitor is there, 10.4 inches touch screen is available, and also there'll be a many user defined keys which you can assign to make your workflow really simple. 4 active transducers, which is micro pinless connectors, and then these machines are based in SSD again to enhance your work, to make it simpler, and full alphanumeric keyboard. Then it has a gel warmer with the 3-step gel warmer, so according to the winters we can adjust. Then overall this is like will enhance your clinical activity, and this is auto IMT feature. Then DPDI, directional power Doppler imaging is available. Then in the cardiology also, it has a high-end softwares like UpStrain, Stressico, then Needle Vision Plus. So it is like the advanced one where you can get full length of needle. Elastography is available for breast and thyroid. Then auto NT. Here precision is the most. So you'll get a very accurate measurements. Then in volume master you'll have multi-slice imaging. Then you have an any slice imaging with the 3 direction. Then we have a live HQ, which is like a fetoscopy kind of imaging. So overall, if we talk about the product, it is like you're getting a good image quality, nice workflow, and with the latest features what we have. So that's all for the BPL presentation. And if any queries, you can please write it down to the Jitendra.
Yeah. Thank you so much. Thank you so much, ma'am, for this presentation.
Thank you so much. Thank you so much, Jiten.
If there is any question or clarification regarding BPL medical technology, you can simply write here on Q&A tab, and we will happy to answer the same. Otherwise, you can simply mail to me. It's at support@microbiosindia.com, and we'll convey your question with and clarification with the BPL guys, and they will answer the same. Is there any question? Is there any question regarding this product and services? Is there any question? ML sir, are you there?
Yeah, I'm there. I'm there. Yes.
Okay.
Presenter?
If there is any question or clarification, you can simply write to me or simply put it on Q&A tab, and we are here, and we will answer the same after the session, or we will mail your query with the BPL guys, and they will answer you the same. So, ML sir, are you presenter now, and you can just simply start sharing your screen.
Yeah, just a sec. Am I audible?
Yeah, you are audible, sir.
Is my screen seen now?
Yeah, just start. Click on start sharing button, sir.
Where I don't see it.
On the left side of the screen, there is a start sharing button. You
Yeah,
can simply
yes, 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 yes. Yeah, I'll click that.
And click on entire screen option, and you can start share.
Yeah.
Yeah, thank you so much, sir. So let's start our second session. This is like the speaker from second session is Dr. Anthony. As a senior consultant and head Lizzie Institute of Radiology Research and Imaging Sciences. He is a past president and secretary for IRA Kerala and past vice president for Kerala, presently elected as ICRI governing body member. So let's start our session. Over to you, sir.
Thank you. Thank you, Jitendra. And good afternoon to you all. I hope I am audible enough. So in the next 30 to 35 minutes, we would go through how ultrasound can help us in diagnosing various thoracic conditions. Now, before we go into this, why should we be doing thoracic ultrasound? We all know that ultrasound is an established tool in emergency and critical care settings. And not only that, nowadays ultrasound is so rampant and so commonly used in all branches of medicine that whenever you do ultrasound, it provides a level playing ground for any sort of clinical discussion. And more important, time has come for us to move beyond detecting pleural effusions in lung ultrasound or thoracic ultrasound. And as you will learn towards the end of this presentation, monitoring treatment, monitoring patient response has become so simple instead of going on repeating chest radiographs. So the indications are varied, any of the chest conditions, but most important is dyspnea. A patient comes in dyspnea or in respiratory failure. We have to differentiate this patient between a cardiogenic cause or a respiratory cause, or in other words, an exacerbation of COPD versus a patient going in for a cardiogenic pulmonary edema. Instead of relying on X-rays, ultrasound can really help you in this regard. Pneumothorax, we have always been relying upon chest radiographs. Now ultrasound provides a bedside opportunity for us to diagnose this condition with 99 to 100% specificity. Volume status of the patient, you don't have to put in a CVP catheter to understand whether the patient is hypovolemic or hypovolemic. Abnormal blood gas, again, you have to know the respiratory status of the patient, the aeration of the lungs. In cases of trauma, the same things apply, starting from rib fractures to collections and to lung involvement can be identified on ultrasound. Pleural effusions and pleural lesions have been the traditional strong point of ultrasound, and that continues so. And diaphragmatic function, in diaphragmatic palsy, it's important you see the diaphragmatic movements in real-time ultrasound, and ultrasound really helps. And finally, intervention. Intervention means either drainage of collection, which could be pleural effusion, empyema, or it could be treating of pneumothorax, or it could be guided biopsy. So these are all the broad indications for ultrasound. Now, I would be concentrating more on lung ultrasound and its various applications. Now, as in any case, or ultrasound in any other parts of the body, we have to go in a systematic manner. Now, the choice is yours. You can divide the one lung or one hemithorax into 2 or 3 quadrants. It could be above the mid-axillary line and below, and you can have 2 or 3 quadrants on the lateral aspect, and same thing repeated in the posterior aspect. Now, the advantage of ultrasound is this ultrasound of the thorax or the lungs, for that matter, can be done on any machine. It can be done using any probe. So whether you have a convex probe, whether you have a linear probe or a curvilinear probe, it doesn't matter, as long as you do the imaging in a sagittal plane between 2 ribs, that is in the intercostal space. So sagittal imaging in the intercostal space using the probes which are available and using the machine which is available to you. So that's the beauty of lung ultrasound. So starting from portable machine to high-end stationary machines, any machine can be put to use to do lung ultrasound. Now, so that is the sagittal image there. We can also do in transverse imaging. Now, as we go by, I would be repeating 3 common concepts. One is sliding of the lung, A lines and B lines. In fact, in lung ultrasound or in thoracic ultrasound, these are the only 3 things you have to know. As long as you know lung sliding, A lines and B lines, you know lung ultrasound. Now let's try to make it as simple as possible. Now this is an imaging through the chest wall. What you're seeing here is the shadowing of the ribs there on both sides, and this first echogenic line, and you see several of them parallel to this echogenic line. So the first echogenic line is what is known as the pleural line, and the lines parallel to this pleural line, they are called the A lines. We'll talk about it much more. Now this has got something like a bat swing appearance. We already know about bat swing appearance in pulmonary edema. So this is an ultrasound equivalent of bat wing appearance, which tells you that you are having 2 ribs on both sides with a pleural line and A lines beneath that. So now this is a video just to show you how it is. So these are the ribs there. You can see the first echogenic line there, and this first echogenic line, what you're seeing here, is the pleural line. And this thick pleura is very important for you. And what you have seen underneath that pleura is the lung, which is sliding smoothly with respiration. Now, in a normally aerated lung, this lung should be sliding under the pleura. So that is called lung sliding. This is of great importance as we move on when we want to diagnose pneumothorax, or when we want to diagnose involvement of the lung in terms of consolidation or alveolitis. Now, this is a representation on linear and convex probes. Linear probes, you can see here, you can see it very clearly. The pleural line is seen and the parallel A lines are seen. The pleural line there and parallel A lines. This can be demonstrated on convex probes as well. Now, why do we get these artifactual appearance? You know that lung or the air contains multiple interfaces, and because of these interfaces, there are reverberation artifacts, and it is these reverberation artifacts which cancel out, and finally you get this parallel A lines, what is known as the parallel lines. These parallel lines are parallel to the pleural line. Now, it's not only on B mode, you can do this imaging on M mode as well. Now, M mode is, you see the movements much more clearly. So that is the chest wall there, and that is the pleural line there. So the sliding lung, you can see here, the sliding lung gives a granular appearance. So this granular appearance together with this placid appearance on top. So this is called as the seashore sign. Now the seashore sign tells you again that on M mode, you are clearly identifying that the lung is sliding pleura is intact, the lung is free to move under the pleura. So this is a normally aerated lung. So this is the corresponding A lines. You can see the parallel A lines there. This is on B mode, where you just see the pleural line and the parallel A lines. While when you do an M mode, you see the placid chest wall, which gives parallel lines on top, followed by the granular or the sandy appearance of the aerated lung, what is known as the seashore sign, which is a normal appearance of normally aerated lung. So that's an enlarged pictorial representation of a sliding lung. So that's the pleural line. The sliding lung on M mode gives this granular or sandy appearance, something similar to the seashore sign where you have the sand underneath the water. This is another representation. Again, sometimes you give terminologies for this. This is known as the key zone, and that is the Merlin zone. That is the sliding lung or the granular moving lung there. Now we move on to the next concept. We have already talked about lung sliding. We have talked about parallel A lines. These lines are parallel to pleural line. So both of them denote that the normal lung, which is aerated, is sliding under the pleural line. Now we move on to what is known as the other important concept of B lines. Now B lines, instead of being parallel, they are perpendicular. But these B lines have certain characteristics, which we'll come to in the subsequent slides. But before that, sometimes you can get incomplete B lines, especially in the lower lateral aspect of the chest wall. So 1 or 2 lines which are not complete, they cannot be called B lines. They are just merely artifacts which do not fit the criteria of B lines. Now, when we talk about B lines, what is important is we are talking about the lung water or the water content within the lung parenchyma. We all know that normally the lung contains more of air. So that is why the lung is appearing black. We are getting reverberation artifacts. Now, as the lung becomes edematous or as the septae becomes thickened due to various causes, either due to inflammation or due to cardiogenic pulmonary edema or due to a neoplastic process or due to a fibrotic process, the air starts disappearing and these septal interfaces start coming in. So then the air loses that normal reverberation artifacts. And instead of those artifacts, you start getting V lines. And as the lung accumulates more of water or more of inflammation, it starts becoming whiter and whiter. That means the fluid content keeps increasing and the air content keeps decreasing. And finally, we reach a stage where lung consolidates, where we call it as gray hepatization of the lung, where the lung almost looks like the liver. So in addition to the normal air reverberation artifacts, as fluid accumulates, the septal lines, which we are all very aware of, what we call as the curly lines, these septal lines, either interlobar or the interlobular septae, they get edematous or thickened. And these thickened edematous septae, we know that they are very thin. They cause multiple reflecting interfaces throughout the lung. And these multiple reflecting interfaces gives rise to what is known as the B line or the comet-tail artifact. So this is a representation of the physics behind it. Lot of septal interfaces giving rise to comet-tail artifact. So that is the comet-tail representation there, and that's the representation of comet-tail artifact. Now this is the pleural line there, and from there you can see this bright line going across the screen, and which is quite well defined. So now, what are the characteristics of these B lines? Now remember, in a normal lung, you are not supposed to get B lines because the normal lung will be sliding underneath, and what you get is parallel A lines. These A lines are parallel to the pleural line. Now coming to B lines, they've got certain specific characteristics. One is the comet-tail appearance, which I have already said, and they always start from the pleural line and then they move along with the sliding lung. So along with the sliding lung, you see these lines also moving with the lung. So these are the 3 major characteristics of B lines. Now, what it means is that once you have this B lines, most of the times A lines will be absent. They are well defined, they are hyperechoic, they spread up as you go to the lower part of the screen and they erase A lines. So comet-tail appearance starting from pleural line and moving along with lung sliding. So these are the characteristics of B lines. If the B lines, the so-called B lines, do not meet these criteria, please don't call it as B lines, because B lines have got tremendous diagnostic importance. So that is a video to demonstrate the B lines, which you can see. So that is the pleural line there. They start from this pleural interface, and then you can see the sliding lung and the B lines moving along with this lung sliding. Now, when do they become significant? When you have two or more B lines in an intercostal space, you call it B plus lines, and most of the times they indicate subpleural part of alveolar interstitial syndrome. Basically means alveolar edema. Now, these B lines, or as the lung accumulates more and more water, the numbers of these B lines keep increasing and they keep becoming more and more closer to each other. So more than 3 or 4 B lines is equivalent of our curly lines, which we talk about on chest radiographs. And as the edema goes on further increasing, they become very close so that they're just 3 millimeter apart, numerous lines. So that is a stage of alveolar edema, where we get bat swing appearance on chest radiographs. Now we have talked about lung sliding. Now, when we do ultrasound, lung sliding can be abolished. That means the lung is not sliding at all. You don't see the lung moving under the pleural line. When you put the M mode, you don't see the classical seashore sign. So then you know that the lung sliding is abolished. So why does that happen? First thing is to rule out any involvement of the visceral pleura. So the visceral pleura is not able to slide against the parietal pleura. This could be due to some inflammation, or the lung is not expanding, or there is atelectasis, or the visceral pleura is separated from the parietal pleura because of air collection, as in pneumothorax. So in other words, there is an abolished lung sliding and air lines are present, you think of pneumothorax. Now, based on this understanding, we can have certain characteristics or certain category of lung involvement. One is known as A profile. That means air lines are present, lung sliding is present. Now, the patient comes to you in severe dyspnea. You place your probe in a sagittal manner in an intercostal space. Do on both sides, posteriorly. Everywhere you get sliding lung with air lines, but the patient is in respiratory distress. So you are absolutely sure that this patient is not having a cardiogenic cause. This patient is likely to have an exacerbation of COPD. Or the other possibility is, if the patient is having chest pain as well, this patient could be having pulmonary embolism. Immediately you go down and do a lower limb Doppler to rule out a deep vein thrombosis of the lower limbs. So the point I want to emphasize or stress upon is, a patient comes in respiratory distress to your emergency department, you don't have to call in for a portable X-ray. Immediately place an ultrasound probe, and within a minute, after going through all the quadrants, your diagnosis is very clear whether the patient should go to CCU or the patient should go to pulmo ICU. So when you have this A profile or the A lines plus sliding, most important is pulmonary edema is ruled out. Now, in a similar manner, we can have B profile, where you get B lines on both sides. So then you know that you are dealing with increased fluid within the lungs. So that is the typical setting of cardiogenic pulmonary edema. And in other words, when you see this, your exacerbation of COPD is ruled out. So the patient goes to CCU for further aggressive management of cardiogenic pulmonary edema. Sometimes you can have A profile on one side. So that means normal lung sliding underneath the pleural line and lot of air lines parallel to the pleural line. So that is normal lung sliding and air lines. So that is A profile on one side, but on the other side, you get B profile. So that means you're dealing with a unilateral pathology, and most of the times this can be attributed to pneumonitis on left side. Now, we are dealing with COVID these days. So we have specific COVID lung patterns as well. We know the involvement of COVID. It is patchy, it is peripheral, it is more in lower lobes. So the similar manner, you get bilateral patchy multiform clusters of B lines. in between you get spared areas because it is mostly in the periphery, and we have clusters of B lines joined together, what is known as light beam sign. And as far as clinical features are concerned, we have reduced leukocyte count and with not much change in serum procalcitonin. And to have a gradation of this, we can have a correlation between CT and ultrasound. As you see, early on, you get just unilateral or bilateral focal B lines. As the disease advances, there are bilateral diffuse B lines. And as the patient resolves, you can see that the B lines disappear and A lines start appearing. So from 0 to 21, if you monitor, your ultrasound appearance parallels almost that of CT appearance. Now, the importance here is once you have done CT and admitted to the patient to isolation or for intensive care, it is difficult later on to shift the patient down to your CT department. But in that case, your ultrasound, portable ultrasound will help you to prognosticate and tell you that whether the patient is deteriorating or the patient is improving. Now, that is just a pictorial representation of already what we know. Aerated lung there. As B lines appear, the aeration starts reducing, and a completely deaerated lung is what is known as the consolidation, what we are talking about. Again, the graph tells you that lung aeration decreases there. So earlier on, the normal lung will have sliding, and as the patient deteriorates, goes in for consolidation, where you can even identify bronchograms on ultrasound also. So these are some of the appearance with COVID lung. Now, what is important in COVID lung is not only that there are clusters of B lines, the pleura gets thickened and the pleura gets disjointed, or there are breaks in the pleural line, which is otherwise a continuous line as we have seen earlier. So just have to look for appearance more break in thickened pleural lines. So in a setting, you can identify this as COVID lung pattern. Other cases, other examples. So A lines, another important feature of COVID lung is, unlike in other pathology, what we have seen, A lines may not completely disappear with the appearance of B lines. Now, when you do ultrasound, the importance is whatever may it be, when the patient comes to you with a lung involvement, you can have differential diagnosis. You can pinpoint the diagnosis. Either it's pulmonary edema because you see a regular pleural line and you see multiple B lines. They show a gravity-related distribution, and there is a correlation to severity of dyspnea. While a diffuse interstitial pulmonary disease, there will be irregularity of pleural line and absent patchy distribution. And bacterial pneumonia is usually lobar consolidation, and you will get A profile on one side, and in a particular area you will get B profile. Now, these are the typical features of pulmonary edema. If you look at here, you can see that B lines, multiple B lines are seen in all quadrants where you insonate the chest. You can see multiple B lines, and they are all emanating from the pleural line. And in a real-time view, you will be able to appreciate that the lung is sliding and these B lines are moving along with lung sliding. So that is the corresponding chest radiograph there. The patient incidentally has a right-sided pleural effusion. So that is again multiple B lines and emanating from pleural line. Now, we can also diagnose interstitial involvement on these lung ultrasound. Now, how do we do that? We know that in interstitial involvement, there is pleural thickening, there is fibrosis happening, and this fibrosis happens most of the times in the subpleural level. Now, depending on whether we are dealing with desquamative interstitial pneumonitis or we are dealing with this uniform pattern of interstitial pulmonary fibrosis, the typical UIP pattern of pulmonary fibrosis, you can diagnose these conditions based on your understanding of the disease process. Now, as you see in this case of desquamative interstitial pneumonitis, it is a patchy appearance and there is thickening of the pleura, and the pleura is pulled in with patchy B lines in both the lungs. Now, as compared to this, if you look at UIP pattern leading to IPF, what you see is as you come down or there is an epicobasal gradient there, there is more of fibrosis in the basal part, so you get more of B lines there, and you see more of thickening of pleura there. And because of the fibrosis which is there, the pleura gets pulled in more and more, so you get more of pleural retraction as you insunate the bases of the lungs. Now, when you have good correlation on chest radiograph and on HRCT, why do we require lung ultrasound in managing interstitial pulmonary diseases? Now, the answer is very simple. When the patient needs monitoring, when you want to know whether the patient is deteriorating due to any other cause, whether infection is setting in, whether consolidation is there, instead of going in for repeated radiographs and repeated CT chest, you can always go for a bedside lung ultrasound and confirm the findings and decide whether the patient is improving or not. Now, other areas of importance, we have talked about consolidation there. And in case of consolidation, we said usually we get what is known as AB profile, that is A profile on the normal side and B profile on the other side. And on this B profile itself, the lung which is above the consolidated lung will give normal right lung, which will give normal air lines, while the left lung will show loss of air lines followed by confluent B lines when you insunate this area of consolidation. Now, consolidation pattern, lobar and alobar pattern of consolidation can also be differentiated on lung ultrasound. And also you can identify or differentiate between atelectasis versus consolidation, because in consolidation, the air bronchogram, if the bronchus is not completely blocked, which most of the cases would not happen, you can see what is known as dynamic air bronchogram. So along with the movement of the lung or the respiratory phase, you can see air coming in and going out of the air bronchogram, so what is known as dynamic air bronchogram. While in atelectasis, you know that the bronchus is completely blocked, the lobar bronchus or the segmental bronchus is blocked, and because of which this air within this bronchus wouldn't be moving in and out. So that will tell you that this is atelectasis, though both the lung will show hepatization. Now, other indications for ultrasound, which we have already talked about, pleural effusion. Now, pleural effusion, the idea is not to visualize fluid, because already on clinical examination and on chest radiograph, we all know that a patient is having pleural effusion. But what is important is to identify whether there is pleural thickening, and if there is thickening, it is uniform or not, and if there is any nodularity of the pleura, or is there any focal lesions anywhere along the pleura. Now, these are all very important, along with the echogenicity of the effusion, because starting from simple transudative effusion, you can have exudative effusion to empyema and hemothorax. So all these will have varying patterns of echogenicity. So looking at pleura, its various patterns, and then looking at the echogenicity of the pleural fluid. And as I've said earlier, atelectasis of the lung can be easily identified. You can rely on whether the air bronchogram is dynamic or not. Now here we can see the pleural effusion there, and you can see the lung which is atelectatic, and you can see the lung edge there, and that is the corresponding chest CT, which shows the pleural effusion and the passive subsegmental atelectasis of the lower lobe. Now, sometimes on chest radiography, you just see this pleural effusion. So all those possibilities which we have been talking about comes to your mind, whether this is a simple pleural effusion or is it an exudative effusion. You do an ultrasound. So that's the liver there, that's the diaphragm there. You identify the effusion there, and this effusion is showing a lot of echogenicity, which tells you that this is not a simple effusion. Of course, this patient was having primary breast malignancy, which was a T4 type, so with a lot of infiltration. Now, when we do pleural effusion imaging, it's not only B mode. Here also we can go for M mode, and on M mode you can see this beautiful sliding of the lung underneath, which gives a sinusoidal pattern, which is known as the sinusoidal lung edge, along with movement of the lung. Now, another case where you have pleural empyema there, pleural lines are seen. You can see the empyema, which gives a lot of echogenicity there, and the collapsed lung next to this particular empyema. So that is the corresponding CT there, which shows this multiple empyema with air fluid level. We talked about lung sliding and the importance of identifying lung sliding and air lines. And we said an important cause for absence or abolishment of lung sliding is pneumothorax. Now, can we diagnose pneumothorax on ultrasound? Yes, with great confidence we can identify pneumothorax on lung ultrasound. How? We identify whether the patient is or the lung is showing sliding or not. Now, remember we talked about normal lung sliding. Normal lung sliding on M mode gives what? What is known as the seashore sign. So that is a chest wall and pleural line there. And the sliding lung normally should give a granular or a sandy appearance. While a lung which is not sliding, or whether the sliding is abolished because of pneumothorax, separating out the parietal pleura from visceral pleura. In that case, you get what is known as the stratosphere sign, which means that they are just similar parallel lines across your screen, which tells you that the lung is not sliding at all. Now we'll see some examples. So now this is a lung which is not sliding at all. You get multiple parallel lines there. You don't identify an air line there. You don't identify the placid waters and the granular appearance. So this is a lung which is not sliding, and immediately your antenna should be up to diagnose pneumothorax. Now, what is the next step? You keep imaging, keep going medially until you reach a point where you see lung sliding and your non-sliding lung together. Now see this is the granular appearance of sliding lung here, and this is the appearance of lung which is not sliding. So now this is the point where these two meet each other, what is known as the lung point. And remember, if there is lung sliding which is abolished, and if you are able to identify this lung point, which is almost 100% specific for diagnosing pneumothorax. So just imagine in an ICU setting where suddenly a pneumothorax is suspected, you don't have to call in for portable X-ray and wait to see it getting developed or getting processed. Instead of that, place the probe, and within a minute or two, you get your answer whether this patient is having pneumothorax or not. So that is other examples. Now, we all know that in pneumothorax, it becomes prominent in expiration, and as the lung expands, it thins out, and that's the pictorial representation of that. So that means whenever you're doing pneumothorax, your visualization of all these findings would be much more clearer in expiratory phase. Another case of pneumothorax there, you can see the pneumothorax clearly on radiographs, and you can identify the lung which is not sliding. Why? Because you don't get the granular appearance of or the seashore appearance of lung sliding on M mode there. And as the patient improves, as the aeration improves, again you can go back and see to it that the lung is sliding by the return of seashore sign. So that is a video representation of this. You can see both the granular appearance as well as the stratosphere appearance, where the lung sliding or the sliding lung meets the non-sliding lung, which gives you the lung point, which is highly specific for pneumothorax. Okay, we already talked about effusions. We can see this irregularity there, multiple irregular lung contour. So the lung has not fully expanded. Now, as in all cases, every investigation, every imaging modality is complementary. It doesn't stand alone or it doesn't work in isolation. None of the imaging modalities are endpoint by itself. It is always a continuum of imaging. So that means chest radiograph, ultrasound, and CT. They are all important as far as thoracic imaging or thoracic diagnostics is concerned. So here, this is a CT case where you can see multiple bullous lesions there, along with a few septal thickening there. So in such cases, when you do lung ultrasound, your findings may not really correlate to the underlying pathology. So always it is in correlation, but there are certain instances where one can rely completely on ultrasound. That is what I have emphasized earlier: exacerbation of COPD versus pulmonary edema, and absent lung sliding and lung point or pneumothorax. So then when we reach the concluding part, what have we learned? Ultrasound of the thorax is a life-saving tool. Why? Because whenever the patient comes in respiratory distress, there is no wastage of time, because even if you take a portable X-ray on time, the patient is in so much of distress that the positioning may not be optimal, the factors may not be optimal, the way the radiograph taken is may not be optimal. So all these features are there in addition to a patient in being in supine position or in AP projection. So all these things may make a chest radiograph suboptimal in an emergency setting, and that is where ultrasound comes in. Patient movement is not going to affect your skill to diagnose this, and the time you take is hardly less than a minute as long as you practice doing lung ultrasound on a lot of normal patients and get used to lung sliding and air lines. So differentiating between respiratory exacerbation, that is COPD exacerbation, versus cardiogenic pulmonary edema is very critical. So there lung ultrasound helps you. And once the patient has pulmonary edema, you can confirm it. And as you initiate your diuretic therapy, you can see actually these B lines, the numbers keep coming down. And finally, you start seeing A lines appearing. So even before you take a chest radiograph and show that the shadows are clearing, lung ultrasound will tell you that, yes, the patient is improving the way he should be. Same thing with pneumothorax. Rely on lung sliding, absence of lung sliding. Try to identify the lung point and then confirm pneumothorax, put in a drain, and once the patient improves by clinical parameters, go again for ultrasound and confirm that the lung is sliding well or the seashore sign has come back. Interstitial lung diseases we have already talked about. We can monitor interstitial lung disease. Remember, ultrasound is not the modality to diagnose interstitial lung disease. Along with your clinical and other parameters, including PFT, it is chest radiograph and HRCT of the lung which will help you to characterize the lesion. But once you have identified or categorized the patient into a desquamative or a non-specific or a UIP pattern, then routine monitoring can be done with ultrasound just to see the number of B lines and the pleural thickening and the retraction of pleura, so you can monitor the patient without subjecting the patient to either chest radiograph or an HRCT. And finally, there is nothing like being a part of a clinical pulmonology team, contributing our ultrasound skill and expertise in the overall management of the patient. Thank you all for this patient listening. Jitendra?
Yeah. Thank you so much, sir.
Yeah.
Thank you so much, sir,
I'll be
for
more
this.
happy to take questions. Yes. Yeah. Yeah.
I'm audible to you, sir?
Yeah, absolutely.
Yeah. Sir, thank you so much for this interesting session. And really, it was really proud for me too, because this is the second time we are here with you, sir. And if you have, guys, if you have any questions or clarification with these presentations on with this presentation, basically on thoracic imaging radio ultrasounds, then you can simply put here on Q&A box, and we will happy to answer the same. If you have any questions, even if you have any clarification regarding this presentation, you can simply mail to us, and we will convey a question with Dr. ML, and he will be happy to answer the same. Is there any question? I think there is no. Is there any question, or like you can simply raise your hand too, and we will. Yeah, sir. One more thing.
Yeah. Yeah, go ahead.
Yeah, Mr. Yeah, Venkata sir, you are now allowed to talk. You can ask your question directly with sir.
Sir, good evening, sir.
Yeah.
Sir,
Good evening.
how to measure the amount of fluid, sir? How to measure the amount of pleural effusion? Is there any
Yeah, that
measurements?
is, that is a difficult thing, because most of the times some people either go roughly in a rough manner. That is, mean they just go and do an axial section and then do a sagittal section and then do this. But remember, when the patient is in supine position, the fluid would have accumulated in the posterior part. So most of the times your estimate could go wrong. If you are able to make the patient sit up, then this estimate could be right. But otherwise, in a supine position, this could go wrong. So
Sir, in
if the
upright
patient is
position, how to measure the
upright position, yes. In an upright position, yes, the patient can sit up. Your calculations would be roughly a good approximation. But supine, I would advise that do not attempt to quantify, but at least you can go by looking at the costophrenic angles. The same thing what applies on our chest radiograph. More, if you see the costophrenic angles obliterated more than 500 ml and so on. So that sort of parameters you can use, but otherwise make the patient sit up and then if you can do that calculation.
Okay, sir. Sir, one more, sir.
Yeah.
One more thing, sir.
Yeah.
Which probe is better, sir, to look for lung ultrasound, whether it is a linear probe or
lung ultrasound? Probes do not matter, but ideally it would be a linear probe, which is better.
linear probe, sir.
Yeah,
Thank
linear
you, sir.
probe.
Thank you. Thank you.
Okay, okay.
Thank you so much, sir. And thanks, Venkata, sir, for raising your hand at question. Hope you're satisfied with the answer.
Okay, sir. Thank you. Thank you.
Is there any more question for same presentation of thoracic ultrasound? Otherwise, you can simply write to me at support@microbiosindia.com. So we will answer your query with the same. And one more thing, if you have any interested with any product and services related with BPL medical technology, you can also simply write to me and we will convey your question with the BPL guy and they will answer the same. And after the end of this session, you will get a notification from our side through BPL link, even the Microbios India latest edition. The joining of today's session will get a free subscription of Microbios India magazines for next 6 months directly to your email ID or your doorstep or your laboratory step. Is there any question? So thank you again. Thank you again for joining us today. Thank you, ML sir, for this mind-blowing presentation. Thank you, BPL guy, for giving us for sponsoring the session. Thank you all of Microbios India crew and colleagues to make this session successful. And would like to inform you that tomorrow is also we have scheduled the session, 2 sessions as we did today. We will start on sharp 10 o'clock by tomorrow, and tomorrow we also have an interesting topic on musculoskeletal radiology and breast imaging. So ML sir, are you there?
Yeah. Thank you.
Yeah, it's good to go now.
Thank
sir.
you. Yeah, good to go now. Yes, thank you. Thank you
Yeah.
for giving this opportunity, and I'm extremely delighted to have come to your platform once again. Thank you all.
Yeah. Thank you so much, sir. Thank you for your appreciating word for me. So let's connect tomorrow. You will get a notification for tomorrow joining link. So thank you.
Thank you all.